Hi there, my name's Kelly Arthurs. I'm a palliative care clinical nurse consultant working for Hammond Care. My two roles at the moment is clinician mentor on the National Advance Project and also working with the Northern Sydney PHN to improve end-of-life care. So we're working on the Quality End-of-Life Project in Northern Sydney in residential aged care. And I'm just going to discuss today advanced care planning. So just to clarify advanced care planning is a process of planning for future health care and personal care whereby the person's values and preferences are made known so that they can guide decision making at a time when the person cannot communicate their decisions. So just to clarify a few of the different definitions and the terminology around advanced care planning, as I said before, advanced care planning is an ongoing process. So we're wanting people to have the opportunity to stop and have a think about what would matter most to them if they became unwell, and reflect and have a think. And once they've done that, have a conversation with their loved ones. And also, really importantly, appoint a substitute decision maker, someone that's going to make decisions on their behalf at that time when they're unable to communicate for themselves. And then the last step of advanced care planning is documentation. And when people do document what their future wishes are, that then is called an advanced care directive. An advanced care directive is a legal document. Advanced care directive can only be completed by the person on behalf of their future wishes. So it can't be done by anybody else. And when it is done by, say, a staff member in residential aged care or a family member, it is called an advanced care plan, not an advanced care directive. And there's a lot of the time, especially in residential aged care, there's a lot of confusion around the differences between those two. The other things that I do come across often is that a lot of family members will come to me and say, I've got power of attorney. And they're thinking that if they've got power of attorney, that they are able to make medical decisions on behalf of an individual, or they are the substitute decision maker. But that's not the case. The power of attorney in New South Wales is somebody that's been appointed to make financial decisions on behalf of that person. If there's a substitute decision maker and people are wanting to appoint that person legally, that person is then called the enduring guardian. So it's really important to know the difference. Power of attorney is financial decisions, enduring guardian is medical decisions. So there's, as I said, there's important steps for advanced care planning, and it is an ongoing process. It's just, I like to say it's not just a form that's completed. As I said, we want to give people time to reflect and think, to talk and share, to appoint a substitute decision maker, and then to document. So more importantly than the form itself is effective communication, and that's really important in all components of care, but effective communication involving case conferencing with families and making sure that everybody's on the same page. Everyone knows the current situation and everyone understands what is likely to unfold in the future for somebody, and then people can make the choices and decisions being completely informed, which is really important. So the potential benefits of advanced care planning is quality end of life in accordance with the person's preferences. It allows people to die in their place of choice. It decreases unnecessary transfers to hospital and reduces aggressive medical care near death, and also improves satisfaction of family and loved ones and decreases complex grief and bereavement. In residential aged care, the ideal situation is that the person in your care is already aware of advanced care planning prior to you meeting them. Ideally, when they were well and living independently at home, the person was given the opportunity to reflect, have conversations with their family, appoint a substitute decision maker, and document an advanced care directive. Also, ideally, the person would have an easily identifiable family, friend, or support network. The family has one spokesperson, and the person has a legally appointed enduring guardian. Also, ideally, the enduring guardian knows exactly what medical decisions the person would make if they were in a situation where they couldn't speak for themselves. That way, the enduring guardian can follow the person's wishes and will not be put in a position where they have to make difficult medical decisions on behalf of the person, as they're just following previously discussed wishes. Family members all agree with each other, and family members have a good understanding of the resident's current situation and what to expect when the medical condition changes or deteriorates. And ideally, family members would live reasonably close by rather than different cities, states, and various countries around the world. But in the reality, people in your care and their families a lot of the time have never heard of advanced care planning prior to admission to the residential aged care facility. People are often having advanced care planning conversations in a crisis situation when they and their family are really stressed, when they themselves are very unwell, or when their capacity is questionable. Many people in your care no longer have the capacity to make medical decisions, and family are left guessing and feeling overwhelmed with the responsibility. And we know in reality that families can be complex. There can be multiple relationships. Children can be full, step, half siblings adopted, and they can be dispersed throughout Sydney, New South Wales, Australia, overseas. And in reality, family members all come from a great place. They all want the best for their loved one, but they often have different ideas and views on what appropriate care is. Some families do have unrealistic expectations regarding medical interventions, and family members may not be informed or on the same page. People, as I said before, are often appointed a power of attorney, but they're not necessarily aware of the definition. And sometimes there's long-standing or recent conflict within families. A lot of the time it doesn't have anything to do with the person you're caring for, and there can be issues around financial and legal matters. There are some barriers from staff, and staff do report that time is an issue because advanced care planning does take time, confidence and experience, and if staff aren't confident with these conversations, often these conversations are avoided. There can be fear of upsetting people or getting it wrong. Communication skills. We need effective communication skills for advanced care planning, so that's something that staff do say that they would like to focus on. There can be confusion around advanced care planning and the terminology and what's important. There can be a consistency in relaying the same information, which causes confusion. There can be concerns about legal considerations, and the quality of forms used aren't always what we would recommend, and sometimes they're stored in a way which aren't easily accessed. So that's really important that the quality of the forms are excellent and they're stored in a place where everybody can find them, especially if they're required after hours. So what we're suggesting staff do is to be prepared. Prior to a family meeting, a case conference, be prepared. So meet with your team prior to discuss, the individual's care needs, what's going on with them, and what is expected for them in the future in regards to their potential deterioration, and have a really good understanding of the current situation and future possible situation. Invite relevant family members to attend the meeting. It's really important to include substitute decision makers in these meetings. And if family can't be there, invite them to attend over the phone. It's really important that everybody's on the same page and has an understanding of what's going on. Be prepared by gathering all of the relevant information required, such as documentation, medication charts, previous advanced care plan that needs to be reviewed, pain charts, anything that would be suitable to share with family members, so people can get the full picture of what's happening. And have a staff member outline the individual's care needs at the moment, and really paint a really good picture to family members about what's going on for that person. One of the tools that we use in residential aged care to determine if we can expect somebody to deteriorate is called the surprise question. So the surprise question is, would you be surprised if the person was to deteriorate and die within the next 6 months? So it's an intuitive question that you ask yourself when you're looking at the full picture of what's going on with somebody, and research shows that health professionals get the answer to that question right the majority of the time. So the surprise question is an excellent tool when you're meeting with your team prior to these family meetings and discussing the individual's care. You're using that surprise question. Another excellent tool to use is the SPICT tool. Yeah, as I said, it's an excellent tool that was developed by the team at the University of Edinburgh, and it's used to help identify people whose health is deteriorating and assess them for unmet supportive and palliative care needs, and then plan their care. So if you're using the surprise question and amongst your staff you're not too sure of the answer and you need some more advice, that's when we use the SPICT tool. So the SPICT tool looks for any general indicators of poor and deteriorating health, and then it looks for clinical indicators of one or more multiple life limiting conditions. And it's really interesting when you're looking at those general indicators, which include unplanned hospital admissions, performance status poor or deteriorating, depending on others for care due to increasing physical or mental health problems, the person has had significant weight loss over the last few months or remains underweight, persistent symptoms despite optimal treatment of underlying conditions, or the person's family is asking for palliative care, or they're choosing to stop or reduce or not have further treatment. So when you're thinking of the people in your care and you're going through this tool, it's really great to go through those points and as a team, answer them. And looking at those clinical indicators, if we're just going to outline dementia and frailty, those other points that you're going to be considering is if someone's unable to dress, walk or eat without help, if they're eating or drinking less, or having difficulty swallowing, if they're urinary and fecally incontinent, if they're not able to communicate by speaking, frequent falls and possible fracture, and recurrent febrile episodes or infections. So I recommend that everybody has a look at the SPICT tool, and there's a link on this presentation. The other documents that we suggest you look at as well is the Enduring Guardianship in New South Wales, which is there with the link, and also the Making an Advanced Care Directive that's it's developed by the Ministry of Health and is available via that website. So just for your information, an Advanced Care Directive will only be used when an individual does not have capacity to decide for themselves or to communicate their wishes. The doctor will only consider the Advanced Care Directive to be valid if you had capacity when you wrote it, you made it by choice, it was not forced upon you, it has clear and specific details about treatments that you would accept or refuse, and it applies to the situation you're in at the time. So what now? What we recommend in residential aged care is to provide people in your care and their loved ones with information and resources. And the resources that we suggest is this one here, the Palliative Care Support for Patients, Carers and Families, which is available via Care Search. There's the link there if you would like to order them or download that and print it off. Also, Advanced Care Planning Australia has excellent resources about advanced care planning that you can share with families and people in your care. To upskill and educate staff, we suggest that you do the Advanced Care Planning Australia free online training modules, and there is the link there to look at. Also, there's free online training modules for clinicians regarding end-of-life law, and there's the link there. Palliaged, which is part of Care Search, they have excellent resources for people working in residential aged care and people working in aged care in general to assist nurses and care workers to provide good quality end-of-life care. And they have Palliaged tip sheets. If you'd like to look at the Palliaged tip sheets, there's the link there for Care Search. And we encourage anyone with an interest in palliative care, working in residential aged care, to do a PEPA placement. PEPA placement is a program of experience in the palliative approach, and it's staff members, and it can be an RN, care worker, recreational officer, GP, with an interest in palliative care, to go and do a placement, an observational placement with a palliative care team. So just to sum up, advanced care planning promotes care that is consistent with a person's goals, values, beliefs and preferences. It prepares people and their substitute decision makers for making healthcare decisions. It improves outcomes for people, their families, carers, health, aged care and community workers, and the health system. And it should be part of routine care and the person's healthcare journey. And it's an ongoing process. Thank you.